Welcome to another episode of Well-Adjusted Mama. This is a podcast dedicated to educating and empowering women from preconception, pregnancy, birth, and through early motherhood on wellness lifestyle. I'm your host, Dr. Laura Brayton, and I'm a maternity pediatric chiropractor as well as mother who has hand-selected experts in natural holistic healthcare specialties to shine light on options and choices during this exciting phase of a woman's life. And this episode is sponsored by Informed Pregnancy Plus, which is a fantastic streaming platform for pregnancy and parenting. You can experience it for free at informedpregnancy.tv. Today's episode is focused on the keys for healthy airway development in children by Dr. Shereen Lim. Dr. Shereen Lim is a Perth-based dentist with a postgraduate diploma in dental sleep medicine from the University of Western Australia. She's been involved in the team management of snoring and obstructive sleep apnea for over a decade. Dr. Lim is dedicated to promoting airway health from infancy as an alternative approach to minimize the development of these problems and their consequences, and is the author of the book, Breathe, Sleep, Thrive. Discover how airway health can unlock your child's greater health, learning, and potential. Her work in private practice is restricted to tongue-tie management from infancy to adulthood, early interceptive orthodontics, and myofunctional therapy. For more information, you can check out her website at drShereenLim.com.au, or you can find her on Facebook and Instagram at Dr. Shereen Lim. Hi, Dr. Lim. Welcome to the show. I'm very excited to have you on today.
Thanks for having me.
So this is always a pleasure to have somebody from down under come on, Well-Adjusted Mama. You practice down in Perth, Australia, and you're a airway focused dentist. So today we're going to focus on keys for healthy airway development in children. I'd love to learn about where you came up with a passion for addressing this type of niche population.
Yeah, my passion really began with treating adults with snoring and obstructive sleep apnea. My husband had snoring, really bothered me, got out of bed one night, super frustrated, decided I was going to learn more about dental appliances. And then I learned about those dental appliances, became one of Australia's first dentists to obtain a qualification in this area of dental sleep medicine. And then I just started to question, how come we're doing these appliances? They're addressing poor jaw development, like it's a Band-Aid solution. Can we grow people's jaws properly in the first place? Can we do things like early interceptive orthodontics? Because that had been proven to improve obstructive sleep apnea symptoms in children. Then when I started to understand that actually the jaws grow the most rapidly in the first 6 years of life, and they're largely determined by how the muscles are working, how we suck, swallow, and breathe, we have a better opportunity to get optimal jaw and airway development in those early years of life through promoting oral function.
Yeah, it makes so much sense to me. You know, as a chiropractor, I'm all about, prevention, right? And like what you're mentioning, what we see with adults with the sleep apnea, which has really horrific side effects when we're talking decades of poorly oxygenating our brain and stressing our heart and, having a several year shorter lifespan, right? For these adults that if it's untreated. Like, why is that happening? Why do some people have it? And we know some people, if they're obese, they might be more prone to it as well. But you're just talking about an average healthy adult like your husband, right? Mm-hmm. And was still having these issues because his jaw was not properly developed as a child.
Yeah, correct. Like you said, it's very despairing. Like today, my last patient was a 30-year-old who has obstructive sleep apnea. And, for some people, snoring is just a noise, but for a lot of people, it is actually creating very disruptive sleep. And this patient described how some days he felt life wasn't worth living. And chronic pain, chronic tiredness, they know they're not living to their full potential with brain fog, memory concerns. And it's just very, very despairing to look in the mouth and think, gosh, this is a very V-shaped, narrow arch. Triangular shape, and his tongue's not really working correctly. And we could have actually addressed this very early on and prevented all these problems, and that anxiety, being medicated for anxiety. A lot of the time, it's a chronic stress of not being able to breathe well. And I think that modern medicine looks at things and medicates people for different symptoms, but we're really overlooking the importance of healthy sleep and breathing.
Yes. And wow, you just gave me an aha moment about my own husband who had broken his nose. So he doesn't have optimal airway through his nose and certainly can snore, which interrupts my sleep.
Yeah,
But it does, there's other side effects, like you mentioned, with anxiety, chronic pain, and just really, and then even people that just don't feel well, like they're more irritable and
absolutely.
um, all of the things. So, and they're exhausted. So, airway is life. It's so important. It's important our entire life. And there's structural reasons why someone can have a compromised airway.
Mhm.
So, let's talk about what you do with children from a preventive perspective and what parents can learn to help support optimal airway development in their child as they're growing and developing those first few years of life.
Yeah, so what we really want to understand is we want good upper jaw development. Good upper jaw development is the template for good lower jaw development. So a lot of the times when we're making these lower repositioning devices for adults with snoring and obstructive sleep apnea, it's actually a symptom of poor palate development, that the lower jaw hasn't developed well. But when we want that top palate to develop well, what develops that palate is the tongue. So that tongue has got to be lightly suctioned to the roof of the mouth during suck, swallowing, and breathing. And it even has to be doing that in utero. So it's that tongue suction to the roof of the mouth is actually molding that palate broadly, so that it is nature's palate expander, that tongue suction. Yeah. So,
and that starts in utero. I didn't know that. I know, like when I look at an infant mouth and they're very tethered under their tongue, I always see a very narrow palate, like you mentioned, which is the base of their nose impacting airway. And I know it's because their tongue hasn't been able to manually lift to the roof of the mouth to spread it. But that's supposed to happen even when they're a fetus.
Yeah, for sure. In utero, when they're sucking and swallowing, particularly during that third trimester, because that's when there's a lot more movements and that's when they're developing their tongue tone. And so we really want to pay attention to that. And number one, most important thing is having continuous nasal breathing, because it's the pressures of the muscles that guide the pressure, how the jaw is going to develop. And it's breathing where we spend the most time. So even though it's a light force, it's a very persistent force of that tongue lightly suctioned to the roof of the mouth with the lips closed that develops the palate. So we want to have nasal breathing. That's like the number one key for good sleep and breathing and airway development. But then we do have to pay attention to breastfeeding, because that first year of life is the window of most rapid jaw development. And that is one of the most modifiable factors that can stimulate good jaw development is having good breastfeeding. Because when we have an effective latch, a deep latch, we get good tongue suction. So the tongue elevates to the roof of the mouth, and as it drops, it creates a vacuum, and that's how milk is efficiently transferred. And the combination of all the muscles coordinating and the jaw moving back and forth, that really stimulates good jaw development. So breastfeeding is really key, as well as, minimizing of pacifier use, because the jaws are so malleable in that first year. And then when we have pacifiers, they push the tongue down and increase inward pressures that distort the palate. And chewing, we want good chewing. So we want to make sure that the muscles are working during all the oral functions so that we can actually promote good jaw development.
Right. And there's myofunctional therapists that work on strengthening these muscles, but in an optimal situation, it's done through life, right? Like that's the things that we do in life to live is what's going to create that proper muscle tone and function.
Yeah. And I think when we begin to do open mouth breathing with the tongue down, or if there is a latching problem at the breast, they are our very first clues that oral dysfunction is going off track, and we're introducing compensations, which means that they will be compounded, because if that tongue is not sufficiently toned and lightly suctioned to the roof of the mouth, during sleep it's not going to be able to rest up there and provide that palate development. And it's not going to work properly as an upper airway dilator muscle or a throat muscle that keeps the throat open, especially during sleep when all the muscles are relaxed. So we actually know that you can function with a tongue tie. You'll actually compensate with other muscles.
Yep.
But the ultimate problems that play out are going to be due to breathing and sleep.
Right. And I think that's one thing too, when I see moms in my practice with their baby, the baby, maybe a couple practitioners have already looked at baby's mouth and they're like, oh, there may be a tie, right? It's like, well, maybe there's a tie there. It's mild, whatever. They're on the fence whether or not they want to do revision and cut those tethered oral tissues, whether it's the tongue, lip, or the cheek ties. And, for me, it's like, and let's say the mom is opted out of breastfeeding, so the baby's getting milk, they're gaining weight, and, they appear to be thriving when it comes to feeding, infant feeding. But so there's an awareness like, well, does it feel urgent to do these revisions because I'm not desperately trying to latch my baby on my breast and get that working. And so we talk about the long-term repercussions, right? That can happen I've seen like a 1-year-old in my practice who did breastfeed and then had a pretty significant tongue tie and had choking, gagging issues with solid foods, for example. Once that tongue tie was released, they were able to eat and not have like even, they were avoiding food because of that gagging reflex. Or then we'll see 2-3-year-olds with speech delays, right? And then we see the 5-6-year-olds with the tongue thrust and then the orthodontic issues and all these compensations. The body is just trying to compensate for this restriction in mobility of the tongue. And also the upper lip, right? The upper lip needs to move as well. So, our bodies are amazing at compensating, but at the end of the day, for what sacrifice? Then we see, the teenagers with that forward head posture, trying to keep their airway open. And now they're 25 with neck pain and arthritis and headaches and, beyond, go on and on. And this is all preventable, right? So I get that parents are like, I don't want to do a procedure that's not necessary. And I get that. Like, we don't want to do anything that's unnecessary, and it's all about function. So I guess, how do you as a practitioner know if this baby, like, when do you leave a tie alone and you don't cut it, so to speak? And when do you always cut ties? Like, what do you think about that? Especially when they're an infant and we don't really know for sure what their long-term development's going to look like.
Yeah, I think it's really important to recognize that tongue tie release is not a quick magic fix. It's not going to cure all problems. Really, our goal should be to always optimize oral function. Mm-hmm. So we really need to work closely with people like lactation consultants or speech and feeding therapists that really understand mouth function to see how well is the mouth working, what are the compensations, how can we get things back on track. So, for instance, if it's an infant, I love working with lactation consultants that can really look at how is the latch, what muscles are they using, how is the body, where is it tight, how is it affecting a baby's positioning, and ruling out all those other variables and training the tongue. We want to train the tongue and strengthen the tongue, ideally, before we get in and do the release. And oftentimes, yes, we want to see improvements before we do the release. We don't want to jump in necessarily. We want to get things moving better, because when we have a tongue tie, our sucking and swallowing is altered in utero. And so it doesn't mean that everything's going to be fixed. There will be compensation. So it is good to get it assessed by one of those people who can actually help identify what's going on, where it could go, and then we do the release to just help them get better function.
Yeah. So what I see in my practice is we do recommend that pre and post frenectomy bodywork. Mm-hmm. And what that does is it opens things up so the revision is more complete. And then it continues to help keep things open and ideally prevent reattachment of those tethered oral tissues after revision. Mm-hmm. And so, yeah, if you're working with like a chiropractor who specializes in breastfeeding and cranial work, like our practice, like they're going to know what to do. Not only they work on the whole spine and the pelvis, because you have to unwind the whole baby's body before you even get into the mouth. Like that's the last thing I do at an appointment. I'm addressing the cranial alignment externally on their head, and then going in with gloves and releasing inside the TMJ and stretching the fascia around the tissue, the tethered oral tissues. And that really then, that will create even some, if there is a feeding challenge or let's say gas, reflux, digestive issue related to a poor latch and seal on the breast or bottle, we see that those babies will improve with a couple sessions. But a lot of times I do feel like we hit a plateau, and that's where the revision is valuable. And even to me, let's say the baby is feeding well after 3 of these bodywork sessions. I guess my perspective is there's still concerns of not, like let's say the lip tie is all the way to the gum line, we're like, the teeth are going to come in gapped, right? And how is that impacting the whole craniofacial development with this baby? So, it's like beyond the function of feeding, I think is what I'm saying. Like even beyond, okay, now they're feeding great, but these ties are still quite significant. And how is that going to impact the rest of this child's life?
Yeah, we're going to compensate with other muscles.
Right.
So typically when we have a tongue tie that's unaddressed, what we'll see is people develop a reverse swallow. So rather than their tongue elevating correctly, they will, like even as an infant, you can swallow and intake excessive amounts of air and have reflux-like symptoms. So some babies may get medicated with reflux medications, serious side effects. No one's really ruled out their latch, whether they're swallowing air. So that's one thing that can happen. But then we continue overusing our lips and cheeks and pursing. And so we don't really develop a good swallow pattern. Or which is important for the solids, and even eustachian tube clearing. A lot of children that have ear infections, they get grommets, then they get them again. I've seen children that have had 4 or 5 sets of grommets.
Those are the ear tubes?
Yeah, ear tubes to drain the middle ears. But what we fail to recognize is a lot of the time we need good swallowing to clear the eustachian tube. That tongue needs to be able to lift. So those type of problems, and like everything that you mentioned before, the way that the palate develops, and how a child sleeps and breathes. When children don't get good palate development and they have a lower lying tongue, they're more likely to have very disturbed sleep. Yeah. And when children have disturbed sleep, there's more problems with emotional regulation, outburst or tiredness, hyperactivity, ADHD type symptoms. And often these children may have that and a bit of lisping, this whole combination of symptoms that's very similar that I see in a lot of children. And we look at the tongue and we can see that hasn't functioned all along. So I do think that it is important that we address this. And I think a lot of more people are starting to understand that there are these implications down the track. And so we can't just think only about breastfeeding. And for instance, today I did a release on a 9 or 10-year-old girl. And for instance, she was referred by a chiropractor and she's had headaches like all her life. She's only 9 years old. Because her tongue was super restrictive, she couldn't move her tongue. She's overusing her neck muscles. And this is creating referred headaches to her head. So before we did tongue tie release, we prepped her with myofunctional therapy. We want to train the tongue where to sit better, the tip of the tongue, get that tongue a little bit more control and coordination so that we're not going to get too much reattachment. And we taught her where to put the tip of her tongue. And as soon as she did that from day one, she stopped getting headaches. So she didn't need to buy any medication anymore. So I think...
And nobody wants to medicate their child. Like that is heartbreaking. I'm curious about
I was just going to say from a chiro perspective as well, when we did her release, because I take pre and post photos of how far they can turn their head, and she even immediately noticed as soon as we did the release, she had so much more freedom in her neck.
Wow.
But they're the things that I think people don't think about sometimes.
Yeah. I mean, those are really important. I'm curious with myofunctional therapy, what age can a child start to learn where to put their tongue? You're not doing this with an infant. So how old? Yeah,
from the age of 2 years, there are these myo spots. They're little stickers that can be adhesive stickers that can be placed in a child's mouth on their N spot. When they say the letter N, it shouldn't touch their teeth. So I think they can be introduced. And what that does, it creates a little bit of awareness for a child. Their tongue can rub up and kind of learn how to elevate, gives them a bit of direction. And if we instruct them to try to melt it, their tongue is strengthening. their tongue tip elevation is strengthening so they can get a bit more control and tone. So even before that, I know that there are feeding therapists that will work with children putting like Nutella or peanut butter in their mouths so that their tongue will lift to kind of train the child how to put their tongue up. So yeah, from a young age, it is possible with a bit of effort.
And even with this 9-year-old, she was able to do that with a severely tethered tongue before her revision. She was still trying to, even though maybe could it even reach? She was just trying to get up there.
Yeah, I've never really had someone that is not able to do it, and I've seen all degrees of tongue tie.
Okay,
we're just asking for the tip of the tongue.
Got it, not the entire thing.
With the mouth closed. Yeah,
right. And I think the other thing too, what about people with even children that are like grinding their teeth? Isn't that a sign of airway issues?
Yeah. Teeth grinding is one of the strongest red flags that a child could have breathing disturbances. So what can be happening for those type of children is that teeth grinding is a stress response to a narrowing of the airway during sleep. So when this happens, it's a protective mechanism. So rather than having obstructive sleep apnea, which is characterized by a prolonged obstruction and deprivation of oxygen, a child's sympathetic nervous system is more on high alert. They grind their teeth, it recruits the jaw muscles. These muscles increase their tone and it keeps the airway or throat open during sleep.
Right.
So even though they're not having oxygen deprivation, it's actually disturbing a child's sleep. It's getting them very restless, unrestorative sleep.
Right. So, yeah. There's in that sympathetic instead of parasympathetic, which is when we rest and heal. So that type of child, I could see them would be that wired and tired, which is that ADHD. Like they're bouncing off. They look like they have tons of energy, but they actually are exhausted.
Or they can present with anxiety, which is actually could be less psychological and more related to the chronic stress of not being able to breathe well.
Physiological. So with these children, like you said, they're not an infant anymore. They're having these symptoms, maybe bedwetting as well. I've seen that with like a 7-8-year-old. That can be a sign of this airway issue. So they're doing myofunctional therapy. They're getting revised tongue. You also do the lip on these older children as well sometimes, or more focused on the tongue?
Most often I will be more focused on the tongue because I want to try to restore tongue to palate suction. It's impossible to mouth breathe, but sometimes we'll look at the lip. For instance, if the lip is really tight to lift and there's a lot of tension, because that can affect the way that jaw can grow forward, the top jaw. But also, when else? I think sometimes there are some children that have a bit of a short upper lip. Their upper lip is kind of held high and it doesn't seal together naturally. So there might be some children like that and it feels tight. I will consider a release.
Yeah. And so, they're also working with a chiropractor, like they're getting all these types of therapies as well, like before and after the release.
Yeah, I would never do a lip tie in isolation. I've just never seen that. But I think for the tongue in particular, with all the connections via fascia to the rest of the body, it is really important. Bodywork plays an important role in every single release that I do from infants through to adults.
Yes, I agree with that. This episode is brought to you by Informed Pregnancy Plus, the ultimate streaming platform for expectant and new parents. Dive into a rich collection of insightful videos from iconic films from Ricky Lake's The Business of Being Born to The Empowering Orgasmic Birth and many others, including my documentary. Explore the mind-body section with meditation, yoga, and fitness classes, including Baby by Simone and Belly Dance for Birth, all with your subscription. Delve into workshops, book insights, and TV-style series covering everything from fertility to breastfeeding. It's a must-have for moms-to-be and birthing professionals. And with apps available for Apple, Android, and Roku, streaming is a breeze. The best part? Try Informed Pregnancy Plus for free. Visit informedpregnancy.tv and start today. So what kind of treatment plan for these children? Like, what does the treatment plan look like? How many, is it like a few months period or?
Yeah, I mean, my go-to option when I'm trying to restore tongue function, obviously we need to make sure that a child doesn't have any major obstruction inside their throat or their nose. So sometimes they'll need an ENT referral, but a lot of the time I will also begin with palate expansion because I want to widen the palate and make more room for the
an
tongue.
appliance.
Yes, an
And what age does that start at?
My youngest that I've done is 3.5. So right now I've limited my intake to children 4 and above. So I'm generally 4. I will start early for a child that is not breathing well, like a child that has snoring, teeth grinding, bedwetting, really disturbed behavior, or just, ADHD type symptoms, tantrums.
Yeah.
Those are the children that I will start early because it's quite impactful. We make more space for the tongue to fit, and then we can do better therapy. And then we would do therapy and try to get the tongue more coordinated and reduce overactivity of the facial muscles and really work on the tone before we do the tongue tie release.
Right. So this could be like the palate expansion could be, I'm assuming, a few months, and that's before they even do the tongue tie release.
Yes, because palate expansion generally in my hands takes about 2 months, and it's very predictable. So basically, if I know a child is going to be compliant with having a plate inside their mouth, you turn a key and every day it expands a certain amount. And so it's just very predictable structural benefits. Whereas my functional therapy is very much more compliance-based. Every child will progress at a different rate. And sometimes people give up. They don't have that sort of time, or their child's not quite ready to comply with it. So I do think even if a child has a tongue tie, if I do the palate expansion first, a lot of the time, that'll help alleviate many of their symptoms, improving their breathing and sleep. It just reduces the urgency or the need to do the tongue tie release. And it just means we can prep a child better. We can help them establish better tone and patterns before we do the release. It just buys us that time, because if we jump in too early, if a child's not prepped adequately, there's going to be an increased risk of reattachment.
That makes a lot of sense.
Know what to do.
So with these children that have the symptoms that you mentioned, you do the palate expansion. They still have their tongue tie. They still might even be somewhat tight in their muscles. How quickly will their symptoms improve, like their behavior, their sleep, their, any of these negative symptoms? Are they improved like within 2 months?
Yeah, generally speaking, a lot of parents will report improvements, whether it is reduced bedwetting, reduced teeth grinding, less disturbed sleep, like more still, more lip closure, generally within that 6-week mark. But everybody is different because, sometimes, for instance, if the tongue is very low, we still got to address that depending on how that tongue is. That could be one outstanding part of it, which will mean that a child may not have complete resolution. But I do think that in terms of what gives the quickest impact in the shortest amount of time, for me, I believe that it's the palate expansion.
Right. And this is like surgically implanted into the palate? Like, is it drilled in? Or is it removable?
For children, the mid-palate suture is very open. It's easy to separate the two halves of the palate with a light force, usually delivered with, for instance, I use removable plates that are worn and anchored to the teeth. And then parents take it out and they can turn a little screw in the middle, which separates the two halves of the palate, and that applies the separating force. And there's other appliances that can be fixed or cemented inside a mouth, but the principle is there's a little screw in the middle that separates the two halves of the palate to stimulate new bone in the mid-palate or the nasal floor.
And essentially they wear it 24/7, except when it's taken out to turn the key.
And brush their teeth.
And brush their teeth. They can eat with it?
Yep, absolutely.
Okay. And they sleep with it. So it's just doing its work a lot.
Mm-hmm.
As a craniopath, I'm thinking, wow, that's all that expansion there definitely would benefit some cranial work at the same time to support all the other cranial structures.
Absolutely. Because when we have a narrow palate consisting of 4 bones, that's part of the whole entire skull. So there's a distortion of that. So definitely, I think where we can alleviate that and open it up, it just allows everything else, all the facial bones and the cranial bones, to be in better harmony. So I think the work that you guys do to help release all that as well in conjunction with the palate expansion can be very important to get better adaptation to that.
It is. And I will say, if I get my hands on a newborn, I typically, and they get their tongue tie revised and all that work done, ideally like the first 3 months of life, we're able to manually expand that palate so it does grow optimally and that child doesn't need a palate expander. So that's even like, have you had cases like, I guess you only see the cases that didn't get that work done.
I don't know necessarily. I think to a degree, I think that can help unlock anything that is strained for sure.
Yeah.
But I do think there are patients with a very significantly high arch palate that will benefit from expansion.
Yes.
We know that even a few millimeters of expansion has been proven to improve the nasal airway. So I'm not really shy about expanding the palate while the child is young, because I've seen the downstream consequences when we miss that boat. So
it's better. I've seen adults who've need it, right? So if you can do it when you're a child, that's certainly better than as an adult. I had a 40-year-old woman with the most narrow palate I've ever seen and had horrible health issues all related to that. And it's been a major procedure doing not only the palate expansion, but now she's going to have to get jaw surgery, and it's a lot more invasive, obviously, the older we are.
Yeah, the bones are more fixed and it's more resistance to all these movements.
Right, for sure. Yeah, I think, the key message here is the more you can do to support infant cranial development and tongue movement and everything like that, the less likely you'll need interventions in the future, which is great. But if your child didn't get those interventions and now they are, 5, 6, 7, 8 and having these symptoms, there is hope. I had a child recently in my practice with enlarged adenoids. The ENT was recommending surgical removal. And this child was an obvious mouth breather, very narrow palate, definitely airway issues. In a case like that, would you recommend addressing the airway and leaving the adenoids alone?
Yeah, so the child had enlarged adenoids. How old was the child?
8.
8, yeah. So the younger and younger a child is, for instance, we can't do palate expansion on a 2-year-old. Some 4-year-olds are not going to be good candidates. So the younger and younger a child is, if they have confirmed obstructive adenoids, which are impacting their sleep, we want to get them breathing through their nose. That should be cleared.
Yes.
And if they are an older child, for instance, I'm going to be more focused on addressing any narrow palate.
Yes.
Because I know that I can do this in 6 weeks and get some sort of improvements. So even while the child's on wait list or waiting for a surgical date, to get in there if they have a narrow palate, particularly the very deep gutter palates, because that is a narrow nasal floor.
Yes.
And so we know that there is now research to support that if we do expansion, say in a child that's 7 to 8 years, Audrey Yoon and team, they did research to show that in this group of children within 6 weeks, compared to children that didn't have expansion, those adenoids and tonsils could reduce in volume.
That was my guess, is that the enlarged adenoids and then some other children could be enlarged tonsils is a secondary effect of mouth breathing, right? When we're breathing with our mouth open all the time, this child was doing it even when they were awake. All of the particles in the air are going back and inflaming that tissue because it's not passing through our nose and getting filtered the way we're optimally supposed to breathe. So to me, like cutting the adenoids out was like just a Band-Aid. You know what I mean? Yeah, I know it's not good to have them, but like it's not their fault, right? Like if you help support the nasal breathing, then that child's adenoids could heal.
Yeah, and actually it could be a little bit more involved than that, but there is, for instance, a hypothesis published by ENT Howard Stupak. And I subscribe to this. He is actually suggesting when it comes to enlarged adenoids and tonsils, the narrow palate could be the root cause.
Oh, yes.
Yes, subclinical
100%.
narrowing of the palate. So when we have a narrow palate, narrow nasal airflow, increased resistance to nasal airflow, we're more prone to mouth breathing. Now, when we breathe through a more narrow palate, we're going to have to breathe harder. So we're inhaling harder, more effort to breathe, and this is going to collapse our throat. And when we collapse our throat, when we have those continuous vacuum pressures during sleep, it actually pulls or draws in those adenoids and tonsils and contributes to their swelling. And so another thing that I see is a lot of children, I see it in their teeth, they have a lot of dental erosion. So we know that's become reflux disease.
Yes.
So I actually think that when children are not breathing and sleeping well, when they're having to work so hard to breathe and they're breathing hard and they're inhaling like that, and then stomach contents can come back up and it sort of aerosolizes in their throat. So that can contribute to the swelling of the adenoids and tonsils as well. So I think at the end of the day, when we have a narrow palate, increased difficulties breathing through the nose, that can be the root cause of these problems lower down in the throat. So I do think that if I can avoid a surgery, I will, because I've seen too many children that have surgery and then they have ongoing problems. But if it means I can't start palate expansion for this particular child yet, and they have really swollen adenoids and tonsils, I don't want to wait too long either, because we know that brain development, they're very susceptible to disturbed sleep. So we can't leave them with obstructed breathing for too long. Sometimes that is the answer to clear the airway for the time being.
Right. But that sounds like that's really the under 4 population. So yeah, with these older kids, the palate expansion, I think what was frustrating is the pediatrician and the pediatric dentist had not talked about the palate, had not talked about the airway or the mouth breathing. They were treating the kids' tooth had a lot of erosions and probably cavity. Like, is that considered cavities as well, or that's separate?
Yeah, if a child is mouth breathing, they're going to be more prone to cavities. And if they have reflux or constant acid in their mouth, yes, these are the children. Whenever I see a child that has rampant caries or decay, a lot of parents say their diet is pretty good. I'm going to question reflux.
Right. And this child did. And so like the dentist was treating all of the teeth issues, right? And it's like, well, what's going on here? Yeah. So anyways, I mean, these cases do exist. And I think what's really exciting is that there's a lot that can be done to improve a lot of physiological function in this child by addressing their airway. And that's so important. And I mean, I'm excited it's becoming more and more there's more of an awareness around it, especially with the pediatric population. You know, I think, and like, even like adults, like, oh, I have sleep apnea, and they get their CPAP machine. Like that was the only option, you know, years ago. And now it's like, oh no, there's a lot of other options. With the adults you treat in your practice, you're using dental appliances, and then they can ideally avoid CPAP.
Yeah, but, you know, again, the dental appliances that we position the lower jaw for, they're really a Band-Aid option. And so nowadays, there's a lot more support that actually jaw surgeries have a very important role. You know, as much as we can take things out of the nose and out of the throat, we really need to work on the outer framework of the airway, which is really the jaws. So the upper jaw forms the floor of the nose, the space for the tongue, and both jaws are the skeletal support for that collapsible airway or the throat. So we know for a lot of the patients, I think that the adult patients are mostly, if we want to try to get them off appliances or get them off CPAP, what we really need to be doing is restoring that missed growth and restoring the jaw structures. And once we've done that and got more space for the tongue and restored better nasal breathing passage, we can actually retrain the muscles and get good tongue tone and myofunctional therapy to keep the throat more open as well. So
do you do jaw surgery, or you refer out for that?
No, I would have to refer out for it.
Yeah.
I actually find it so despairing, because sometimes it's a more invasive surgery.
Yeah.
And, you know, sometimes, for instance, where I'm from, there's not a lot of recognition from orthodontists that you can actually do this, and it, like expansion, for instance, and it can improve breathing and sleep. So it's very frustrating for adults to go and try to get opinions from people. And so that's why I believe in early intervention. It's so much easier. And we can save people decades worth of struggle.
Oh, yeah. I mean, this poor woman who I mentioned earlier, who's 40, has just gone through a lot. And
Mhm.
she couldn't even tolerate CPAP. She tried CPAP. It was like blowing her cheeks out like she
Yeah.
was in a wind. So it's like, but she's really she's chronically tired and
Mhm.
poorly oxygenated, right? Like this is really a big thing. She has chronic neck pain and headaches.
Absolutely.
So, but like,
And
jaw surgery is intense. Like you mentioned, it's invasive and it's major. And it definitely at this point, it's her best option when she's done with her palate expansion. But like to your point, she's working on her upper jaw, then she's got to work on her lower jaw.
Mhm.
And this is years. So if we can address this with children in a few weeks, I mean, this is such a better option than waiting until we're, older. What's the oldest patient you've had in your practice?
Oh, I can't remember exactly, but with the tongue tie releases, I will do them for adults. No
Yeah.
upper age limit.
Yeah. Anybody. And then you're also obviously doing palate expansion with these adults as well.
No, but with the palate expansion, I'm really more focused on the 4 to 7, 4 to 9 group.
Mm.
The traditional age for palate expansion for children is between the ages of 7 to 8 years. But as I've started progressively seeing younger and younger children and just seeing the functional benefits, it really makes sense for me to start early because then we can help children function better to their full potential. So
Yeah.
for me, now that 7 to 8, it's actually almost starting to get older. It's too old because I want to get into children. I can get a really good dental result if we can get in before the first permanent teeth come through. I like growing the bone to create that better foundation for the teeth to drop through in better places. So yes, for children, my favorite age is probably about 5 to 6.
Yeah.
But I will start younger if a child can benefit more from it.
But what if the child is now older, like they're a teenager or whatever, and like they still need it, right? Like you can
Yeah.
do palate expansion even with an adult.
Oh, sorry, this is sort of in my practice, but definitely palate expansion can
Oh,
be done at any age, even
yes.
in adults, because there's now new innovations to allow that to occur, where before we thought that you couldn't really separate the mid-palate suture in an adult. But
Mm-hmm.
now we have new ways of doing things with the use of TADs or mini screws that can be placed inside the bone on either side of the suture. So what that means is we can put a screw mechanism and attach it to those mini implants. And what that means is the force can be placed more directly across the mid-palate suture, and we can sort of open or separate the two halves of the palate more easily to stimulate new bone, as opposed to just moving the teeth. We can actually get the same sort of palate expansion results for adults using these innovations. So I
Right.
think it is possible, but things are fairly new. Not every orthodontist is trained in this in their program. So
Right.
yeah, but a lot of colleagues in this space are getting palate expansion. It's just become a more and more common thing that people are looking for.
So, how does a parent find a dentist like yourself in their area that like does dental sleep medicine and airway specialty? Like, is there a website that they can look for people who have this special training like yourself?
Yeah, it's really hard to say. I mean, I get like inquiries every single day from people wanting to know where can I go locally. So at the moment, I have like a few directories, a list of directories, and I cannot vouch for every single person, but I think they are the good starting points. So for instance, the AAPMD, the American Academy of Physiological Medicine and Dentistry, directories like Airway Circle, the Breathe Institute, those type of directories. You will get to find people from different professions, whether it's chiro, dentistry. If you can connect with someone there, they may have a network of other people in that community that they can.
Yes, I definitely find that in my area. Like the people that are doing airway work, we all know each other because we're all
Yeah.
co-treating the same patients and we really value co-treatment. I think that's the other key here is recognizing that this is airway issues is not just a one practitioner treatment, right? It does require a team approach to get the best results.
Yeah.
I want to also just, we have to wrap up soon, but I just wanted to have you talk a little bit about your book, Breathe, Sleep, and Thrive. Can you tell us about that?
Yeah, the book is really about connecting dots for parents of how important healthy breathing and sleep is for a child to function to their full potential. What are the warning signs? And what are the things that we need to look at from birth to ensure optimal airway development? And if that goes off track, what are the various avenues or paths to help things get back on track? Because it's never really just a one solution. It's a multifactorial problem. And so it really helps parents to find those pathways and understand what they can do at every age.
Oh, I love it. It's so important. There's really only, from what I know, a handful of books out there like this that really talk about pediatric sleep apnea, pediatric airway. And I'm excited for more parents to know about this because it's really the missing link for a lot of childhood illnesses or symptoms, I should say, like the bedwetting, the ADHD, that those could be medicated, right, by their pediatrician, but they're not addressing the root cause. And that's always, what we want to look for is what's creating these symptoms and not just like you mentioned earlier, masking with the bandage approach, but really actually addressing, optimizing airway and seeing how a child will thrive and their symptoms resolve just by improving their airway. It's really exciting. Absolutely. So thank you so much for coming on the show today. Any last thoughts you want to share?
No, I was going to say thank you so much for bringing airway health, this message to your audience.
Oh, of course. Thank you so much, Dr. Lim.
Yeah, thank you.
Dr. Lim and I are definitely soul sisters. We have a lot in common with our passion for team management and really preventive solutions for the development of a proper cranium that really begins right after birth. Even honestly, in utero, there's some cranial development that's happening that pregnancy can impact. And then, of course, after the birth process and everything through infancy, toddlerhood, and beyond, that impacts the growth and development of your child. So if we can get in working on these children when they're very little and supporting them in optimal craniofacial development, we can drastically impact their trajectory as humans. So if you want to learn more about this topic, specifically airway and children and how to support your child's airway and why it's important and all the symptoms related to poor airway issues, please check out Dr. Lim's book and get it on Amazon. Breathe, Sleep, Thrive. Discover how airway health can unlock your child's greater health, learning, and potential.